here by 10 o'clock, so everybody can get back to the office. There are a few kind of redundant questions. A number of people had the same question up here. So this has been asked of Dan and of Maureen. But is there any chance the many deadlines will be moved back?
Start.
I think there's a chance deadlines for some of the rules that are being made will be moved back, but the law is the law. So, you know, based on the components of the law saying that exchanges will be effective January 1, 2014, that has to happen. In what manner it happens may change based on the rules that they come out. But I don't know that without congressional action, they could say we're delaying this until 2015.
I mean, that's for the most part true. They can't delay whether or not the exchange goes forward on 2014, but rules, guidance, everything's been delayed from the very beginning. Whether or not, and this was asked of me last night by Chris, will exchanges be up and running by January 1 of 2014? And my answer to you is it probably will. You probably will see a federally facilitated exchange that'll have a website that will allow you to look at a couple of 3 different insurance companies and potentially enroll online. But will it be automated? Will you automatically know what your tax credit is going to be? No. Will Medicaid eligibility in that same system be ready by January 1, 2014? Extremely doubtful. So there will be deadlines pushed back. There's been deadlines of when the exchange, when states needed to be ready to operate the exchange have been pushed back. And quite frankly, that'll push back even states that are operating their own exchange that probably won't be ready January 1, 2014. That'll have some type of a hybrid between the Fed and the state. So I do believe that deadlines, just as a matter of course, will be pushed back out of necessity.
Barb, does Obamacare include a tax on real estate sales? And if so, what is the percentage and when does this take effect?
The answer actually is yes. What people are asking about is if I sell my personal residence, is there going to be taxation on that? The answer to that one is your primary residence, there is an exclusion from income for married couples up to $500,000 in gain. That income is excluded and exempt from taxation, so therefore it doesn't increase your income, therefore that's not subject to the tax. However, if you sell your cottage, you sell a second residence, that's going to be capital gains, just like if you sell a piece of GM stock or Procter & Gamble stock, and if your income is over $250,000, yes, it will apply, that Medicare tax will apply to that passive income, because that's capital gains, interest, dividends. It also applies to net rental income, so if you have a rental property, and that's also passive income. All of those items are passive.
If you have a rental property.
Or if you have an investment in property that is not your primary residence. The primary residence is excluded. Life insurance benefits are excluded, unemployment benefits are excluded, and distributions from your retirement plans are excluded from the net investment income.
Okay, so as a real estate owner, I don't feel any better. Thank you. Dan, today most companies have an enrollment rule that states that employees must average 30 hours per week to be eligible for insurance. Is this going to change now that everyone needs insurance? And do the exchanges have to prove solvency?
The requirement on average hours worked for benefits is not a state law or a state regulation. It is a carrier practice. I don't anticipate outside of what the law states in terms of 30 hours a week is going to change from it. Carriers are going to do what they can to the maximum point of the law. So it's not a state law, so that that won't change from the state's perspective. As to whether exchanges need to be solvent, it's not the exchange. The exchange isn't one large pool. The exchange is nothing but some insurance companies competing on a website. Those insurers in the exchange need to be solvent, and then the big question is, how do we ensure that solvency do we have the same legal recourse and the same legal remedies that we have today on the outside market to go after those carriers within the exchange. Then you throw in multi-state plans, and there's no guidance on multi-state plans yet, and that's also another big question. But it will be our goal that we will fight very hard that those insurers must have the same solvency requirements in our state as the folks operating outside the exchange.
Thank you for clarifying what an exchange is. Dan, what are navigators?
I think they're insurance agents. I mean, if you look at what the navigators were intended to do, they were intended to, and it states within the legislation, they were intended to help consumers understand the myriad of options that are available within the exchange, and to guide them and help them attempt to enroll in that exchange. So as we viewed it, it looked, you know, if it walks like a duck and talks like a duck, it looks very much like what an agent does. And so from our perspective, we're looking at them as advisors of some sort, and that's where we would love to, and we're going to try to create a regulatory scheme around that, so that if they would in fact give bad advice, we have the ability to make the consumer whole.
So just a little bit to add up on that, do you feel navigators will replace our trusted agents in Wisconsin, and if so, what impact will they have on employers or employees?
Will they replace an agent? No, because they're not supposed to give any insurance advice unless they're a licensed agent. So you've got these navigators that are supposed to talk about enrollment and how to operate within the exchange, or how to pick a plan, but they're supposed to walk up to and not cross this bright line that says you're not giving insurance advice. Well, that's where we have grave concerns. You know, if you're saying go into the $500 deductible versus the $250, that's giving insurance advice. And so by definition, by law, they're not supposed to do that. They're supposed to walk up to that and not pass it. And we'll come up with some type of regulatory scheme to make sure that they never cross that line, and if they do, that there's consequences. But because they can't give that insurance advice, they can never replace an agent other than becoming licensed as an agent and doing what agents do.
Thank you.
Are they employed by the government, the navigators?
The navigators are intended to be nonprofit. They're intended to receive all of their funding through grants originally, operated through the feds. So the grants through the feds are supposed to operate and provide the funding for the navigators. And then once a state is has an exchange and they're up and running, the exchange is supposed to be able to accumulate, after the grants go away, dollars in order to fund those navigators. So that's the intention of the legislation.
Maureen, would taxing employer-provided health insurance premiums lower healthcare costs?
No. Because premiums have no relation other than of being a reflection of healthcare costs. Again, that the carriers don't set the rate that a physician or a hospital charges for services. Your premium is a reflection of that. So taxing premiums would simply put more money into the tax coffers. It would not address the fact that the cost of care is continuing to increase and the unit costs are increasing. And that's unfortunate in terms of the piece that's been missed here. That was the intent, was to lower the cost of care. And there's nothing addressing the cost of care. Other than carriers and Network Health is doing so, are trying to strengthen our partnerships with providers so that we can create innovative products and relationships between, and with wellness programs, as was mentioned earlier, to strengthen the relationship between the carrier, the provider, and the member/patient, so that we're all working in concert to bring health to the highest level we can, address issues that exist, and provide the most appropriate care at the most appropriate cost. And that's really being driven by the carriers in concert with the providers, and then working to bring the patients into that picture as well. And to me, that's the huge miss here. Nothing in this massive, complicated law addresses the actual problem. if I can get on my soapbox just for 1 second. And I've been on this soapbox since the early 90s. You know, we do things in this country that aren't allowed anywhere else in the world. Ours is the only country in the world that allows direct-to-consumer advertising by pharmaceutical companies. And the cost of care rose immensely when that happened in the early 90s. If you remember the ad that said the little blue pill may be for you, scores of people went to their physician to find out if that was true, but it didn't even say what it treated. The ad did not even say what it treated. When this started, I had 4 magazines that had 27 pharmaceutical advertisements in them. This changed the way people approach the receipt of care, and they go to the doctor to see if this will work for me. I asked a member of CSIO, which is another acronym you hear. It's a division that became, due to the healthcare law, it's the Center for Consumer Information and Insurance Oversight. I asked this question because the speaker posed the question to the audience, if you have any ideas that could help, let me know. That's the question I posed. Why don't we stop direct-to-consumer advertising? And her answer was, if you want to get a call from every TV station and radio station in the country, pose that. And my answer to that is, now we know where our influence comes from. This could reduce the cost of care, yet the lobbyists, the advertising dollars that are involved in it are too big for them to touch.
I promised I would not step on the soapbox, but that kind of...
I can't help myself.
made me jump on mine. So, and I just want to touch on the direct-to-consumer advertising. If you look at how prescription drugs were paid for in 1993, there was no drug card. There was no put 4 quarters down on the table and get any drug for any price. If you remember back in 1993, and unfortunately I do because I'm old enough, you would get a prescription, you would go to the pharmacy, you would write the cost of that entire bill to the pharmacist, and then you take your receipt home and you would put it in the shoebox, and then in a quarter or so, you would, 3 months later, you'd collect that receipt and another receipt and send it to the insurance company to show that you had satisfied that part of the deductible. Direct-to-consumer advertising would have never have worked. The reason direct-to-consumer advertising came about, in my opinion, is because we came up with this drug card that allowed someone to come up with $1 for any prescription at any price. And once the pharmaceutical manufacturers realized that cost was no longer a issue for the consumer, that's when I think the direct-to-consumer advertising occurred. It was the benefit design, and it was how cost shares are designed, and that has always been the problem in health insurance and third-party payments. When there's third-party payments and you remove the consumer from being a consumer and caring about the cost of the price of that service or good, the price of that service or good is going to go up. It's simple economics. And so the fact that this particular legislation somewhat makes it disadvantageous to have those high deductible and large cost sharing arrangements, I think will further lead to the increase in healthcare costs versus its intended goal, which there was nothing in there to reduce healthcare costs. But I think there's almost an incentive for healthcare costs to go up because of some of those, the effort to focus on as little cost sharing to the consumer as possible within the legislation.
One last add there, sorry, but office visit copays did the same thing. And I was there in 93 and 94 when we developed these benefit plans. So, I mean, I raise guilt. We did this. Insurance carriers did this through benefit design. But the other, a fact that's a little bit unknown is that for small employers, no individual that's part of a small employer group will be allowed to have a deductible higher than $2,000 individual or $4,000 family. So increasing cost again. If someone has selected a $5,000 deductible today, in 2014, they're going to have to move to a $2,000 deductible if they're an individual, $4,000 if they're a family. That's for anyone over the age of 30. Someone under the age of 30 is allowed to purchase a catastrophic plan. So when you hear, if you like what you have, you can keep it, I can give you numerous examples where that's not true. Well, There's a question about Hearst, but I'll let Dan answer that when we get to that.
That happens to be our next question. Dan, what will happen with Hearst, Badger Care, and Badger Care Plus?
Hearst First is the high health insurance risk sharing plan. It's the high risk pool in the state, and because of the guaranteed issue and the market reforms within the PPACA legislation, there is no need for Hearst anymore, and so Hearst will go away. Even if you continued the program to let these high risk individuals go into Hearst, once they realize that they can shop somewhere and be guaranteed accepted and guaranteed issued, there's no purpose for them to be in Hearst. From our concern, Hearst is paid for through not only the premiums paid by the consumers, but through assessments on insurers, and there's going to be additional assessments on insurers as it relates to reinsurance pools, as it relates to risk adjustment, and we don't want another assessment on the insurers to artificially raise premiums. And so our office will be making the recommendation to do away with Hearst. It's when it goes away is the only thing we're making the decision on. As far as Badger Care and Badger Care Plus, that's Medicaid, and so whether or not we do the Medicaid expansion, that's not our bailiwick. That's Dennis Smith's bailiwick. We'll let DHS make that decision and the governor. But there will be a Medicaid program, and whether or not that's still a component, Badger Care is still a component of that is yet to be determined. But there will be a Medicaid program. To what percent of FPL it will go up to.
Can you just expand on the Hearst thing for a second? How many people participate in that program right now in Wisconsin?
Right now it's about 20,000, 20-some thousand, 22. It has grown. There was a federal high-risk pool as well, and you sit on the board, but what's the final number right now? 24,000. And it has grown. It has grown through the state more than it has the Fed. The Fed program really didn't get a lot of action on it. One interesting note, and it goes back to when you're talking about enrollments and how big these enrollments are. You've probably seen in the paper recently of how Badger Care continues to shrink. The enrollment in Badger Care is dropping. That is a direct effect on the cost-sharing arrangements. So Badger Care is intended to help those that can't afford coverage, and they had certain contributions that they had to pay, which was almost nothing. And within the legal limits that we had, DHS has raised some of those contribution levels, not only in what they have to pay, but in some cost-sharing arrangements with deductibles and so forth. Every time that they've gone in and raised a little bit of those cost-sharing arrangements, the enrollment continues to drop. And so I think what that does is set up a pretty good crystal ball as to what happens with the exchanges. So if the exchanges and the subsidy for the exchanges don't provide, in essence, almost free coverage, will the uninsured and those that are in Badger Care sign up for the exchange, the federal facilitated exchange with the subsidies? And we kind of got a glimpse, quite frankly, with Badger Care and adding more cost-sharing arrangements, that I think the sticker shock for some of these folks when they think they're going to look at free insurance when they get on the exchange is going to be pretty high sticker shock. And I don't think with the $95 penalty that you're going to see anywhere near the number of reduction of uninsureds in the state has been predicted.
I was starting to think of the dollar signs of 24,000 individuals. If you can't charge them an additional cost for their pre-existing conditions, then everyone's going to be paying that. So my $471 monthly premium is not going to be that.
It's not. No.
Oh, I'm so happy I came today. Barb, regarding 2014 benefit reporting on W-2s, are all benefits treated as taxable income?
Oh, that's a good question. The answer is no.
The answer to that is no. This is a reporting issue. They're not taxing health insurance benefits, and the description in the IRS literature is that they're doing this to give employees information with which they can compare various options. That's probably not true. If you're getting health insurance for your employer, why do you care? You just know they're paying that and anything. A lot of employees would probably just think, oh, he's just trying or she's just trying to show me how much they're paying on my behalf and I'm not paid enough already anyway. What it really is going to be is a way to tell if you have a Cadillac plan, because if you have that insurance reporting on there and that's a high number, the IRS will have a way to track it. They'll also now, again, know if you have if you have more than 50 W-2s, and there's health insurance reported on it, they're gonna be able, that's their way to provide you the notice. This is a cost-sharing penalty. They've gotta get reported in order to be able to do that. But health insurance premiums are not taxable right now to the employee, and they are not scheduled to ever be taxable to the employee.
Great. Do we have questions that perhaps weren't asked, that weren't written down, that people would like to ask?
With the question where you said the little known fact for small employers, and small employers is defined as in that avenue 25 or less, or 50 or less, and then does that go away with the HSAs then, if that deductible limit's lower?
I'm not sure how the non-compatibility with HSAs is going to be addressed. They have said that they will allow some leeway in terms of deductibles if it doesn't match, but that's about as far as we are for that right now. The small employer that I'm referring to for the state of Wisconsin would be the 50 full-time employee, or 50 full-time employees, the state definition. Unfortunately, there are multiple definitions of small employees as small employers, as Barb indicated. On a national basis, the PPACA, the law, has taken the employer's small definition from 1 to 100, but they have allowed states to retain their definition of small employer, which in Wisconsin is 2 to 50. I forget which year it is, 2016, I think, that everyone has to move to the 1 to 100 definition of small employer.
They can ask for an exemption for that though, as well, and extend to another 2017, I believe. And then just one thing on the HSA, and I just wanted to be clear. The law says 2,000 and 4,000 as far as the maximum deductible, but because of the essential health benefits and the #1 rated, we went to the federal default because we decided not to come up with an essential health benefits scheme because we weren't able to, #1, get some answers yet from the feds, but #2, we were limited to just the options. So the federal default is the top writer in the state, and what their top selling plan is. Their top selling plan is a HSA deductible that's greater than 2,000. So in Wisconsin, the minimum coverage is going to be higher than $2,000 deductible. I don't remember exactly what the number is, so don't quote me on it, but it will be higher, and that information will come out soon. So.
There was a question in the back.
Oh, okay. Oh, go right ahead.
Requirements, legally what insurance companies must include in their plans, and as far as, maybe, for instance, I want a catastrophic plan, I'm 80 years old or whatever, I don't want coverage for me. I don't want coverage for, you know what I'm saying? Isn't there some room that, hey, people can take policies, hey, I want coverage for this, this, and this, and you know, I can exclude them. I don't need them. I don't want abortion coverage. I don't want contraceptive coverage. You know.
I'm going to let someone answer that question because the answer is no, and I don't want to be blamed for that. So the answer is no, and I apologize. So the essential health benefits tells you what type of cover, hospital, physician, etc. Go ahead.
So is the answer no because the Fed is imposing this, or is it because it's our own legislature?
No, it's the feds. And what it did is that unfortunately the legislation said that whether you operate within the exchange or outside the exchange, these will be the essential health benefits that must be provided, whether that's individual coverage or group coverage. And so that ties our hands as a regulatory body to say what we want to do in Wisconsin. Our hands are tied because of that federal, and federal law does preempt us. That we're sure of. We've researched that.
Okay, so before this ObamaCare took effect then, was that the case, or did our own state legislature, were these laws in effect because of our own state legislature?
So, For the answer to the question is, for the most part,
I guess that's a bygone, but I was just wondering.
the state legislature has over the years decided what should be in an insurance plan and what shouldn't be, called mandated benefits.
Right.
As an agency, we're not supposed to be pro or con against mandated benefits, but we know what the end result is on mandated benefits, and it forces a consumer to purchase something they may or may not want to buy. We don't think that's consumer choice. But the legislature over the years has implemented a series of mandates, not as extreme, particularly in the individual market, as the essential health benefits, but the mandates that we have won't be added to, but they won't be subtracted to once the law starts in 2014.
So essentially, as it was, the Wisconsin legislature, our hands are tied. We can't do anything to make it in our own state.
Unfortunately, no.
See, aren't we glad we came? So, just 1 second, if you don't mind, another question popped up here. So, we're going to give an example here. A company offers health insurance, and they pay 50% of the employee's premium. It's a voluntary program and it's HSA eligible. The question, will our company health insurance program face change to our program? I.e., will we need to change our 50-50 split? And
That's actually the 50-50
goal.
split, the contribution.
The employer contribution today of the 50%, that's directed by the insurance carriers. That's so that there is not adverse selection on those enrolling in the plan. I have not seen any information, you can correct me, Maureen, coming through yet that contribution would be changing at all. But I think what was addressed earlier, and Barb, I'm going to give the mic to you then, on how you calculate what is going to be considered affordable coverage in terms of the family total income.
It could affect the employers in 2 ways. First, if you're a small employer as defined by less than 25 for the tax credit that small employers can get, then you have to pay at least 50% of the single premium to get that credit. So that's number one. If you meet that and you still meet it, you'll continue to get that credit. But if you're talking about the shared responsibility for if you do have a small group health plan, you have more than 50 employees, but now you have to determine based on the plan that you have, is it too expensive? Is it more than 9.5% of your employees' household income, considering that safe harbor rule out there, where you can just look at the W-2, then you may or may not have to make changes to your plan and not get hit with that penalty. And that would be individual to your own plan. You have to use that calculator to know.
And what was the percentage of the W-2 again?
9.5%.
That's just a flat.
It's just a number they pick. And that's actually can give you an idea. If you pay someone so much a year, take it times 9.5%, how much does that come to in a month? Where are you? Are you above, below? So now is the time to start get a feel. Am I above that amount, below that amount, so that I know how this may affect me before 2014 comes along.
If an individual doesn't buy health insurance on January 1st of 2014, are they locked out for that entire year and waiting to the next open enrollment? So is there an annual open enrollment for individual health insurance if they do not select, and they would not have the option for a group plan, let's say? So would they be locked out for the entire year not to purchase individual health insurance?
Is this on? Yes. There's an open enrollment for individual health insurance that runs from October 1st, 2013 for January 1st, 2014 effective dates through March of 2014. So anyone can come on during that period. What is still being determined is what do you do with someone that does not enroll? Will there be some type of, you can only go in this plan if you don't come on when you were first eligible? Do you pay more? Do you have to wait? Not answered. So how people that don't enroll during their eligibility period will be treated has not been answered. The other question that's not been answered is for someone who has already purchased or purchases insurance in 2013, let's say July of 2013, my renewal is July of 2014. I'm able to keep the coverage I have until my renewal. The plan I bought in July of 2013 will not be compliant in July of 2014. So I'll have to move to a compliant plan. That's obviously outside of the open enrollment period. So how will that be treated? Will they then be considered eligible and they can move on to a compliant plan with no penalty or waiting period? Has not been determined. Those are questions that have been asked that are outstanding.
And then if they do have an individual plan, would they have the freedom to move throughout the course of the calendar year to any other plan that they would like?
Question is, can they then move throughout the course of the year to any other plan that they would like? That is also at question. That is also at question.
So the guidance so far has been that the FFEs will likely stick to an open enrollment period, that once you're in a plan, you're not able to switch to another plan. The only guidance, that's fairly determined so far by HHS, so if you're in a plan, you can't go to the next plan unless you're in open enrollment. If you're currently uninsured and trying to get coverage, it hasn't been decided, although they've hinted that they want it to be in open enrollment. But right now in Wisconsin, unless we change our laws in our state starting January 1, 2014, if we don't do anything legislatively in our state, then insurers that are outside the exchange have to have guaranteed issue, and we don't have an open enrollment period, so they can technically get coverage at any time with insurers that operate outside the exchange. So we are looking at tightening up our laws so that our insurers outside the market don't get adversely selected against from the carriers operating within the exchange.
That's right. And as a carrier, we're hoping that will be the case, because obviously the selection inside of the exchange would be different than outside. So if someone can't go in because they're outside of the open enrollment, they'll come to us and we will have to issue.
So all those same rules apply to somebody that went through a private exchange, right? It doesn't pertain to the subsidy. If I go to a private exchange, do I still have to go to an annual election period? Or can I go in the private exchange and have freedom of choice with the private exchange?
Well,
If I can take a subsidy.
private subsidies are available only on the exchange.
Good,
First.
the public piece.
The public exchange. When you talk about private exchange, that's really kind of a whole new subject. Private exchanges are mainly, at this point, an employer-based exchange. There are some private exchanges out there where Ann Hewitt, for instance, has one, and the employers that are part of that, their employees can select any carrier. So the employer may say, I'm paying, $300, and you can choose any carrier. So the employer could potentially have 100 employees that are on 12 different health plans, 12 different carriers. The subsidy does not apply there.
The rules on the private exchanges end up being the default as the outside the market rules. So how, as a regulator, we would treat the private exchange as outside of the market, outside of the exchange, because private exchanges are no different than an insurer doing a direct contract with an employer. It's not federal facilitated exchange. So there's no difference.
Clear as mud, right?
Yeah, I've got 5 more pages of questions to ask.
One last question, back there.
There seems to be some confusion today around HSAs. Two things that I'm hearing different. Deductibles, there appears to be some kind of limit, has been mentioned. And also, I've heard that there's supposed to be some grandfathering if you have existing HSAs. Can any one of you speak to that?
I'd like to believe he's older than me.
I am a grandfather, thank you. I
I'm a
have 3
grandmother
grandkids.
too, so.
3. It allowed for, and this was intended for the statement, if you like your plan, you can keep it. And the ability to grandfather a plan for a small employer, and I'll let Chris answer this because she's the expert on it, is almost non-existent. It's almost impossible to grandfather a small employer plan because of various changes, and I think they're the consultants, I'll tell you this, but I think they're making recommendations. Do whatever you need to do to save money and operate a plan that you can afford. Don't worry about the grandfathering clause. But even within grandfathering, it only exempts you from small pieces of the legislation. So there's been a lot of to-do about the grandfathering of plans and that's your safe harbor, it's not much of a safe harbor at the end of the day, and I think Chris can probably verify.
It sounds good at the end of the day. You know, if it's sold well, if you like the plan, you can keep it. But all the small employers that we work with, any plan design change, deductible change, prescription drug change, anything that happened, it basically took them out of that realm. I think out of all of the small businesses we work with, we had one that would be considered grandfathered. It sounded good in the beginning.
Thank you. I think we're going to close out because now we're at